I am Dr.C.Rex. I am describing the three-wire K-wire technique for distal radius fracture fixation, which is called the Kovai Technique, which we've been practicing for last 20 years in Rex Ortho Hospital, Coimbatore. So here we use two dorsal and a single styloid 3 K-wire technique, which biomechanically very strong. And if you look at the technique, we use two dorsal wires, one through the Lister's tubercle, one through the lunate fossa fragment, and the radial styloid wire from the lateral aspect. So this is the technique which we follow. And after close reduction, there are a few points which you need to check it up to make sure and the C-arm guidance that you achieve all the reduction, you satisfy all the criteria after the close reduction. Only then you can proceed for the K-wiring technique, which can be practiced percutaneously. So the post-reduction checklists are: you need to maintain the length and height of the distal radius. The normal palmar tilt must be established of 11 degrees. The radioulnar congruity must be maintained without any radial translation, and the intra-articular fracture congruency must be maintained. I'm showing the surface marking of the distal radius and the ulna with a prominent Lister's tubercle, and with this we will proceed to the live video. This is a case of extra-articular fracture of distal radius with a dorsal displacement and a typical Colles fracture. The radial styloid, you can see, is the height is reduced and is almost the same level of the ulnar styloid, and the dorsal tilt with the dorsal displacement of the fracture. And in the AP view again, you can see the radial inclination is very much reduced. So we need to correct all this by closed manipulation, and I'm going to demonstrate the three wiring technique percutaneously. This is how in the theater the patient is placed, the arm table, the C-arm at the head end, assistant sitting at the head end of the patient. I'll be sitting on the side of the arm table, and the typical dinner fork deformity of the distal radius because of the dorsal displacement, and we need to reduce this fracture by close manipulation. And so I'm going to give traction holding the middle three fingers and thumb, and my assistant holding the other side of the arm, giving counter traction, steady traction for 30 seconds. So this impacts the fracture. The radial styloid length is regained, and you're feeling the radial styloid correspond to the ulnar styloid, and usually it's about a centimeter distal to the ulnar styloid. Once it's regained, then you do a manipulation of volar flexion and ulnar deviation of the fracture site, and holding the hand in the volar flexion ulnar deviation, using a roll towel underneath to use it as a fulcrum. You hold the reduction in position and check in the C-arm to know how good your reduction is. So here, maintaining the traction with the roll towel underneath, you can see in the AP view anatomical reduction of the distal radius with the regaining the styloid length of the radius. The radius is regained its length, disimpacted. And similarly, looking at the lateral view, you can assess the palmar tilt, which is about 10 degrees, is again reproduced nicely. So this is how we should do a good closed reduction. Once you achieve the good closed reduction and the fracture is well reduced, then you can proceed with the fixation either by percutaneous K wiring or by the plating. This is a Lister's tubercle, and the dorsal and distal most prominent aspect of the distal radius. The ulnar styloid is well felt, and this is the radioulnar joint. So the surface marking is done for easy understanding. And first, I make a skin incision on the Lister's tubercle, just distal to the on the Lister's tubercle. So here, once you made a small nick with the 15 blade knife, you can use a small mosquito artery forceps to spread the soft tissues and feel the Lister's tubercle. So nothing on the way of K-wire when you poke in with the K-wire, so no soft tissue will come in the way. So once the soft tissues are retracted with the mosquito forceps, use the K-wire to feel the dorsal rim of the Lister's tubercle, and then checked in the C-arm and with a 45-degree angle and or through directing on the long axis of the radius, you are penetrating the far cortex, and once the far cortex is felt, you stop it and then check it in the CM, AP and lateral view for the radial tilt, the reduction of the fracture, the palmar tilt, and all these are maintained or not. This is very important. The first wire must be placed with the anatomical reduction. If there is any displacement or loss of angulation, then probably you need to take the wire off and redo the whole thing from the beginning. With having this first wire in, you cannot manipulate again because it is transfixing the K wire, and the second wire now was put in at the radial styloid level, just distal to the radial styloid. The CM, you can see the lateral view centering on the lunate. So centering on the lunate, the K wire is placed, and once the marking is done, and again using the mosquito forceps to spread the soft tissues apart so nothing is on the way. The K wire is placed at the styloid process tip, ensured both in the AP and lateral view, and actually it will be in the lateral view, it will be in the center of the lunate. And once it is in position, the K wire is run at an angle of 60 degrees to the long axis of the forearm, and you can see in both AP and lateral how much it is angulated to the long axis of the forearm, and one can feel the piercing the near cortex and the far cortex, and a sudden give way feel after piercing the far cortex, and it should stop immediately so it doesn't impale the soft tissues in the far end. And the third K wire is made by making a small nick on the dorsal rim at the lunate fossa fragment. So this is the dorsomedial K wire. So you can see at the dorsal rim of the lunate fossa fragment, and spreading with the soft tissues. And my K wire is going to enter on the dorsal rim of the lunate fossa fragment, and checked in the C-arm for the perfect position, and then the 45-degree angle it is entered, pointing in the long axis of the distal radius, and once pierced on the far cortex, stop immediately so it doesn't overshoot, and then you ensure in the AP and lateral view the position of all three K wires. So you can check in the AP all the checklists and make sure that the criteria of reduction is maintained by transfixing with the K wire. As I said earlier, the length of the radius, the palmar tilt, radial nerve joint alignment, the congruity of the distal radius, and also the radial inclination. So all these points are checked again to make sure you have an anatomical reduction. So this is the final picture, the AP view, and the radial nerve joint is well maintained, and this is the lateral view showing the three wires in position, and again it is well maintained, as I said earlier. So now I'll show you how we bend the KYs. This again is very important, especially when you put a wire in osteoporotic bone. And here the assistant should hold the K-wire close to the skin using a plier, and this the K-wire bender is inserted on the K-wire and leaving 3 to 4 mm of the wire distal to the plier. You start bending. You should not go very close to the plier. If you go close to the plier it may pull out. So by doing this, you are able to bend the wire nicely, almost more than 90 degrees. So all wires are bent in a similar fashion. From the plier, leaving 3-4 millimeters away, you start bending the K-wire. And make sure you don't rotate the wire when you bend these wires. And the wires are cut leaving 4 to 5 mm distal to the bend, so it doesn't migrate inside. These wires are kept outside the skin, and no skin impalement is there, as checked by the mosquito forceps, to make sure you feel go up to the bone and no soft tissue tethering, and easily you can see this. There is no impalement of skin at any point in the movement. So this is very important, as in the post-operative period you start moving the fingers and there must not be any impalement, otherwise the patient will complain of pain. And after doing the bending, again it's better to recheck on the C-arm again that nothing has been pulled out, or you don't get any loosening of the wires. But if you feel so, it is better to change the wire rather than to accept. So always you have a low threshold to change the wires in case if you feel the wire is loose or not holding good. So that is very important. And these bent wires are dressed using a Vaseline gauze around the bent K-wires, and this will prevent migration of the K-wire inside. And also we wrap a gauze piece around the bent wires in all 3 wires, and a small pad is given on the dorsum and a bandage. This is a simple wrist brace which is used in the immediate post-op. We give it for 6 weeks, and taking the brace off, you exercise